So, just mentioned, on general inspection, patient is standing comfortably. Is he on any arm swing? Is there any assistive device or orthosis next to the patient? On closer inspection, on the attitude of the bilateral upper limb, left side appears to be normal, whereas on the right upper limb, shoulder is adducted, internally rotated, forearm pronated, and there's clawing deformity of the fingers. Okay? Alright, then after that, you look at the shoulder. Swelling, scar, sinus, skin changes, any wasting of the muscle. Alright, and then any obvious deformity. Alright, so you look around. And then after that, you feel, is there any increase in warmth? Just like I show you guys, the shoulder examination. And then after that, you palpate slowly from the sternoclavicular joint, along the clavicle, down to your ACJ, down to your acromyon, according to the spinal scapula. Then, move. Boleh ikut saya. And I can tell you, it'll be just like that only. You won't be able to move. Just one side. And just check one side, everything. Alright? So then after that, I said there's no movement possible over the patient's right shoulder. Okay, alright. So, you see, up to here, shoulder examination only, right? Look, feel, move. Now, you're gonna check the neurology of the upper limb. Alright? When you are checking the tone, you also need to check the suppleness of the joint. Alright, so how do I check, you see? The tone, like your usual upper limb tone, forward flexion, extension, flexion, extension, flexion, extension, flexion, extension. See how it's the tone. Tone usually will be hypotonia, because it's a lower motor neuron lesion, isn't it? Right, then after that, you need to check the suppleness of the joint. Why do we need to check the suppleness of the joint? Because if you want to do any procedure, for example, tendon transfer, the joint has got to be supple first. Understand? Because if the joint is not supple, like this fixed contracture, you do a tendon transfer, it's not going to work. Right? It's not going to produce flexion also because it's contractured already. Alright? So you want to check the suppleness of the joint, you roughly bring through to the range of movement. How much? Flexion, how much can it reach? Extension, how much can it reach? Alright? So the same. Finger, wrist. So these two are actually incorporated together. Tone and suppleness of the joint. Okay? Then after that, you check for the power. C5 to T1. Just like just now, what we checked. So C5, deltoid, and then after that here. But in BPI, a lot of times they won't be able to do all this. We're just at the side. Very clear. Alright. So, if you want to check the gravity eliminated for C5 or deltoid, you need to do like this. You can need to slide down. So patient, C5, they can't do like this, right? This is because this is with gravity. The only test that is possible for C5 to check the shoulder abduction with gravity eliminated is you flex the patient's elbow, hold the wrist, place your hand at the lateral aspect of the patient's deltoid. Ask them to abduct against resistance. Yes. So this is C5 with gravity eliminated. Okay? Understood? This is C5. Alright. But usually, you don't straight away lie the patient down. Only until you check everything finished, only then you lie the patient down to just check this particular C5 with gravity eliminated. Okay? Alright. Then you stand back. Then the rest of the C5, you check like this. Patient won't be able to do this. So, you do this. Can or not? And then you look for flicker here. So usually it's either MRC grade 0 or 1, something like that. MRC grade 0, no flicker. MRC grade 1, there is a flicker. Usually. Usually. Then after that, extension. Extension, they won't be able to do this also. Most of the time because very clear. Then ask them to do this with gravity eliminated. This is C. C7. Alright. Then after that, they won't be able to do this. Do this. This is C6. Okay. Then after that, they won't be able to do this. Ask them to do this. This is C8. Alright. And then after that, T1 is this one. Alright. So, power also done. Tone and suppleness. Power. Then you do reflex. C5, C6, C7. Okay. Reflex also done. Then sensory. C5 to T1. C5, C6, C7, C8 to T1. Just like your normal cervical spine just now, your neurology. Alright. Now, this is the part. Then after that, you palpate for the radial pulse. Alright, because brachial plexus injury usually is a like high energy injury associated with a lot of vascular injury. So you need to check that, because that is very important for our management. So if you want to transfer any muscle, if we transfer to a limb that is with a compromised vasculature, it's not going to survive. Alright, then after that, you check for the potential donor. This is a bit higher level already. I think if you can reach here, then you will be able to know whether it is a pan-plexus or upper plexus or lower plexus. But most of the time, it will be either pan-plexus or upper plexus. Lower plexus, very rarely. Very rare kind of injury will have just lower plexus only. Usually it's traction like that, and then you got an upper plexus, alright? Or pan-plexus totally. Lower plexus alone is very rare. Okay. Alright, so if you got a pan-plexus, that will be the findings. Totally clear. Alright. If you get an upper plexus only, so C5 and C6 only, alright, their hand will be okay one. There's no muscle wasting here. Their movement C8 and T1 all okay. Sensory of C8 and T1 will be okay. But they won't be able to do any of this because their C5, C6 are affected. Okay? Alright, that's the difference between upper plexus and this one. Then the next thing you can do is a Horner syndrome, right? To determine whether it's preganglionic or postganglionic. So Horner syndrome, you've got your ptosis, myosis, and anhydrosis. Alright. So when you shine your torchlight, you shine it at your nose bridge, not at the eyes. The eyes one is for the cranial nerve examination. You just shine it at the nose bridge here and then see whether there's any myosis or not. Okay? Then after that, you feel at the forehead any anhydrosis. So for Horner syndrome, you do this. First, any anhydrosis. You look at the eyelid, any drooping of the eyelid, ptosis. Then you shine the light at the nose bridge, any myosis. Okay? Alright. So then after that, you look at your scapula, preganglionic or postganglionic. If there is a winging of the scapula, is it preganglionic or postganglionic? It's preganglionic. Alright. Why? Because there are only 4 nerves that are arising from your preganglionic area. This includes dorsal scapular nerve, suprascapular nerve, long thoracic nerve of bell, and also your nerve to the subclavius. So when you have a preganglionic, this will be affected. So that's what we are looking at. Dorsal scapular nerve supplies your rhomboid here, rhomboid minor, rhomboid major. Your serratus anterior, long thoracic nerve of bell, alright, will allow your scapular retraction, isn't it? Okay. So when you have your when you have your preganglionic injury, you have winging of the scapula. Is it going to be medial or lateral winging of the scapula? It will be medial. It will be medial winging. Alright. So how do we tell whether it's a medial or lateral winging of the scapula? Based on this thing. You do a midline, and then this one you have got a superior medial border of your scapula, superior medial border of the scapula. If it moves towards the midline, it's called medial winging. If you move away from the midline, it's called lateral winging of the scapula. Just as simple as that. You see the superior medial border of the scapula, whether it's moving towards the midline or away from the midline. That's called medial or lateral winging of the scapula. Medial winging is what you would see in a BPI. Alright? So just forget about lateral winging. It won't come in your exam. So you don't have to crack your head. Is it medial or lateral? Medial or lateral? If it's an orthopedic examination, it's going to be medial winging only. Lateral winging is due to the injury to your trapezius. Trapezius is supplied by your spinal accessory nerve. So usually, when they take a cervical lymph node biopsy, they could accidentally injure this spinal accessory nerve, lead to trapezius weakness. Only then you will have lateral winging of the scapula. Okay? Alright, so that's what you see. Alright, so for those who can reach this level and then after that can go beyond, you need to identify potential donor nerve. Alright, potential donor nerve, there are 7. Alright, potential donor lah, not just nerve only. Potential donor, there are 7. 1 from the top, 2 from the front, 2 from the back, 1 at the knee, 1 at the foot. 7. Alright, first you ask the patient to shrug their shoulder. Shrug. Actually, don't let me push it down. You see, what am I checking? This muscle? Trapezius. Okay, so just now what did I say? What nerve supplies the trapezius? Spinal accessory nerve. That's why your spinal accessory nerve is one of your donor. Okay, you want to check the power, whether the spinal accessory nerve is working or not. So SAN, spinal accessory nerve, number 1. Number 2, from the front, pectoralis major. Alright, pectoralis major is one of your potential donors. So how you check? Hand, inner aspect here. Hand, feel at the pectoralis major here. And then after that, can you compete? Feel for the muscle bulk of pectoralis major. Okay? Alright, so that can be used as a muscle transfer. Number 3, another one from the front is your intercostal nerve. All this, your intercostal nerve, alright, can be used as a potential donor. Leave it out. Look at the scar here. Why we look at the scar? Because patient with a high traumatic injury, high energy injury, could have a chest tube insertion. If there is a chest tube insertion, it could injure the intercostal nerve. Then we cannot harvest that anymore. That's the reason. Alright. So you just look for the scar of the chest tube. Any scar of the chest tube here. That's all. That's all we see. You can't really test the intercostal nerve. Alright. Okay. Now from the back. Okay. Look from the back. You place your hand around the patient's back here, and then ask the patient to turn either side, left or right. And after that, cough. Feel for the muscle bulk. I'm checking Latissimus dorsi. You go back, you Google the image Latissimus dorsi. Where does it attach to? Then you just feel here and then cough. Okay, this one is working. So Latissimus dorsi. Alright. Now, another one from the back is your phrenic nerve. Alright. So you just do like your lung percussion. Okay. If your phrenic nerve is paralyzed, what will happen? Phrenic nerve supplies what muscle? Diaphragm. Alright, so you have your elevated hemidiaphragm. Okay, one diaphragm, two sides. So if one side is called hemidiaphragm, alright, if you got a paralysis of a phrenic nerve, it's called a elevated hemidiaphragm on that side. Okay, then it will be down, isn't it? Because it doesn't fill with air anymore. Right, it will be elevated hemidiaphragm. So that's what you check. Okay, got it? One from the top, SAN. So you test the trapezius. On the front, pectoralis. Ask them to compete. Number 3, check for any possible injury to the intercostal nerve by inspecting the chest tube scar. Then go towards the back. Latissimus dorsi. Ask the patient to cough. Number 5, phrenic nerve, elevated hemidiaphragm. Okay, then you ask the patient to sit down. Okay, can you sit here? See where I place my hand now? One hand behind the patient's calf. The other hand, I'm palpating for the pes anserinus here. The hamstring tendon. Alright? And after that, move your leg behind. Okay. Then it will be top. You test on your own. You test on your own. You palpate here. And then you go. You can feel the tendon, isn't it? Right there. Because your pes anserinus is say grace before T. Heard before? No. SGT, it is quite universal one. Pes anserinus, sartorius, gracillis, semitendinosus. Alright. Because we want to harvest the muscle called gracillis. That's why we check here. The tengah-tengah one. Sartorius, gracillis, and semitendinosus. If the muscle heels are not working, and then it's quite a chronic injury, we can harvest the gracillis muscle here and transfer this gracillis muscle to the hand. So that it will work. So that's why we check that. Last one, number 7, is you check for sural nerve, because that can be used as a nerve graft. So where do you check for sural nerve? You look for 2 things. Number 1, if we harvest a sural nerve, it will be between your Achilles tendon here and the lateral border of your fibula. Alright, so it will be at the midpoint. If we harvest, it will be from here all the way up here. So you look for any scar. You look for scar. See whether the sural nerve has already been harvested or not. Then after that, you check for the sensory sensation over the lateral border of the foot. Lateral border of the foot. This is the innervation of your sural nerve. Okay, so for sural nerve, you check for 2 things. Whether it has already been harvested or not. And then after that, whether there's any loss of sensation over the lateral border of the foot or not. That's all. Alright? Okay, thank you. So how you want to summarize and how you want to manage, huh? So, huh? On this side, alright, this one I increase the temperature. Okay, 32. Alright, so you're gonna say that from my physical examination, the relevant positive findings include a lower motor neuron lesion affecting the right upper limb, involving C5 to T1 or C5 C6. You see, the reason for this session is that so that you don't go to the exam and think just because based on the book, alright? Because lower plexus alone is not going to be possible. It's very unlikely. So you don't go like, could it be just lower plexus only? You know, I mentioned those kind of things. Then you can straight away take out that option already. It's just going to be usually upper plexus C5 C6 or C5 to T1 only. Alright. So again, from my physical examination, the relevant positive findings include a lower motor neuron lesion affecting the right lower limb, involving C5 to T1 as evidenced by hypotonia, areflexia of C5, C6 and C7, loss of sensation along the dermatum, alright, and then the weakness in C5, C to T1 or C5, C6 like that. Alright. So provisional diagnosis, most likely they will have a trauma lah. Usually it's a trauma, motor vehicle accident, high energy injury. So you say, my provisional diagnosis is a post-traumatic right upper limb pan-plexus PPI. Pan-plexus means C5 to T1. Or if it's just C5 T6, this is a post-traumatic right upper plexus BPI. Okay, that's a provisional diagnosis. Now, differential diagnosis can be anything. Brachial neuritis, thoracic outlet syndrome, alright, multiple cervical radiculopathy, but it's rare. Okay, mind you that if it's a cervical radiculopathy, usually one nerve root or two nerve root, like just C5 or C5 weakness, C5 numbness, or just C6 only. It wouldn't be like C5 all the way to T1. It's so bad, so bad. No. Alright, but yeah, you can put it as a differential diagnosis, lower down. Alright, so management, just a general idea. Usually during the acute trauma, okay, then they come in, you do the plain radiograph first. Alright, you do the cervical because what do you call? Not cervical. Chest X-ray. Alright, chest X-ray. You want to look for any possible transverse process fracture of the cervical, lower cervical spine there. Alright, and then after that, you want to look for any clavicle fracture because your brachial plexus just passes underneath the midpoint of your clavicle. Alright, if there's any fracture there, it could injure your brachial plexus. Alright, yeah, that's for the X-ray. And then X-ray in a chronic case. Alright, you do a chest X-ray because you want to see elevated hemidiaphragm. In order to see that, you need to do chest X-ray in full inspiration and full expiration, and you compare. Okay, so in an acute case, you just do a normal cervical chest X-ray only. Alright, but in a chronic case, in case you want to harvest the phrenic nerve, you need to do a chest X-ray in full inspiration and expiration. How do you diagnose BPI? Is it clinical, radiological, or how? Clinical. Alright, so do you need MRI? No need. Alright, don't ever mention MRI. Don't ever mention MRI in a BPI case. We never do MRI in our BPI case. Okay. Now the thing is, then after that, acute case, acute BPI, patient come in, you clinically diagnose already, or let's say whether it's a pan-plexus or upper plexus injury, preganglionic or postganglionic, then your management is going to be like, put the patient on an arm sling. Okay? To prevent the muscle going into atrophy, so what you do is that you can do transcutaneous electrical nerve stimulation, TENS. Put it there, stimulate the muscle. Alright? And then after that, you do stretching. and the range of motion, because you really don't want the joint to go into contracture. Because you go into contracture, even your neural ties and all that, not going to work also. You neural ties ready, or you got your biceps function ready, but already contracted, you cannot flex also. So these are your priorities. And if the patient has got any shooting sensation, for example, root avulsion, give pregabalin, gabapentin for the patient. Okay, again, management for BPI during the acute setting, which very unlikely for you to get, all right, for your exam, all right, because they would have already selected the this one a few weeks beforehand. I was partially involved also in the previous batch when selecting the this one. I was in charge of contacting the orthopedic patient. Yeah, so I already know the cases for the previous batch. Okay, all right. Again, conservative treatment. Put on an arm sling, put tense, prevent muscle going into atrophy, and then stretching, and then range of motion exercise to maintain suppleness of the joint. Any neuropathic sensation or pain, give pregabalin, gabapentin. Alright, nice. Now, when do you do surgery? It's a bit more advanced. BPI is actually a bit more advanced, I think. The answer is only one. Absence of useful motor recovery by 4 to 6 months. You ask you when to do surgery for BPI. Answer only one. Again, standard answer. Absence of useful motor recovery by 4 to 6 months. And by that, I mean MRC grade 4 and above. If MRC grade 3, what you want to do? We just gravity eliminated. At least 4. Right. If it doesn't improve until MRC grade 4, right, by 4 to 6 months, you need to tell the patient, you need to do some surgery. Okay, what kind of surgery? Alright, so you divide them into less than 1 year or more than 1 year. Why we take the cutoff point as 1 year? Because the motor end plate will degenerate at 1 year. So if you do before 1 year, we do neurotization. Neurotization means we transfer the nerve. Alright. I think as to the specific nerve, what nerve to transfer to what nerve, I don't think you need to know. You just need to know we can do neurotization. And the cutoff point is 1 year. Because the motor end plate has not degenerated yet. It's still alive. Alright. But of course, the longer you delay, like for example, if you do a surgery for one patient at 5th month, or you do another operation at 11 months, outcome is very different. Alright. So less than 1 year neurotization. More than 1 year salvage procedure. For example, tendon transfer. That's why we check for Pectoralis major, Latissimus dorsi, and Gracillis. Okay. Why we check these 3 muscles? Because we want to use them for in more than 1 year, kind of a chronic BPI injury. Okay. Alright. So tendon transfer. Now, another thing you may need to know is that in terms of priority of surgery, alright, because it's all clear, alright, you can't do everything in one setting, alright. So usually we prioritize, number 1, if you see in the book, elbow flexion first. Elbow flexion is number 1 priority. Number 2, shoulder stabilization. Okay. Number 3, brachial thoracic pinch. Brachial thoracic pinch means like this. Can copy, so that they can copy the newspaper and copy all these things. That's number 3. Number 4 and last one is wrist extension and finger flexion, so that they can grab things. Again, the priority of surgery in BPI, elbow flexion, followed by shoulder stabilization, followed by brachial thoracic pinch, followed by wrist extension and finger flexion. Okay. But realistically speaking, we don't do this, then we do this. Why? Because it's time sensitive. Alright. So for example, like I said, absence of useful motor recovery by 4 to 6 months. 4 months already, no useful motor recovery. You counsel the patient, you need to do surgery. Second, 5th month, you do this one, and then 3 months later, once the patient recovers, 8 or 9 months, then you do this. No. So, in reality, we do these 2 together. Probably by about 5th or 6th month. 4th month like that, you start to plan for the surgery. 5th or 6th month, then we do the surgery. Elbow flexion and shoulder stabilization using neurotization procedure. Alright, because less than 1 year. Okay? Understand so far for BPI? So you can see that it's just the same as your shoulder examination. Then after that, you follow up with a neurological examination of your upper limb. Tone, power, reflex, sensation. Of course, you need to check the suppleness of the joint. And if you can complete all this and tell that whether it's a pan-plexus or upper plexus ready, only then, for higher level one, you check for potential donor. 7 potential donors.
Doctor,
Yes.
last time you were asked to find brachial plexus patient.
No lah. Last time contacted one is Charcot arthropathy. Then all the ligamentous multi-lig injury. Sports I was mainly in charge of contacting sport patients. ACL, PCL, and then some meniscus and all that. Yeah. Alright.